Hello and welcome to CLS 535, looking at childhood trauma and how we as child life specialists can support the child during times of difficulty and helping them to develop resilience. So we're going to start our conversation by looking at what is trauma, and trauma can mean different things to different individuals. And so just to make sure that we're starting all on the same foot, we're going to start by having a definition or defining trauma. In general, trauma can be defined as a psychological, emotional response to an event or an experience that is deeply distressing or disturbing for an individual. However, it can also encompass the far extreme and include experiences that are severely damaging, such as rape or torture. So trauma is a deeply distressing or disturbing experience. It can also include physical injury, but doesn't necessarily have to. And in general, it is that psychological emotional response. And when it's loosely applied, it can refer to something upsetting, such as being involved in a car accident or having an illness or injury, losing a loved one, or going through a divorce. Trauma is really based on the perception of the individual and how they perceive the experience and the way that they're processing the experience. As I mentioned, it can also encompass the extreme and can include severely damaging experiences like rape or torture. It really is all about the perception and the processing of the experience. Two individuals with a similar or same experience can have two very different perceptions of the experience. So everyone processes a traumatic event differently because we all face them throughout our lifetimes and through the lenses of our prior experiences. Because trauma reactions fall across a wide spectrum, psychologists have had different categories developed as a way to differentiate between the different types of trauma. Among them are complex trauma, post-traumatic stress disorder, also known as PTSD, and developmental trauma disorder. So we're going to look a little bit more at each of these different types and what encompasses each of these different types. Complex trauma happens when you have trauma that's happening repetitively, and so it's multiple traumas, happening repetitiously. It often results in direct harm to the individual, and the effects of this, what we see is that the effects are cumulative, so it's building on each experience. The traumatic experience frequently transpires within a particular time frame or within a specific relationship, and often in a specific setting. Now, different from this, post-traumatic stress disorder is when a person develops responses after having been exposed to a terrifying event or one that has been through an ordeal in which intense physical harm occurred or was threatened. Those that experience post-traumatic stress disorder then have persistent and frightening thoughts and memories of their specific experience. And so we're also going to look at some of the responses of individuals to toxic stress, to traumatic stress, when they have experienced repeated stressors, and the way that that can affect the individual and can change the individual physically, developmentally, biologically. And then we also have the developmental trauma disorder. Now, this particular trauma or this experience of trauma is a relatively recent term in the study of psychology. And with this particular type of trauma, the disorder forms during a child's first 3 years of life. Now, this type of trauma is often the result of abuse, of neglect, or abandonment. And some of the effects that we see then is that it interferes with the infant or the child's neurological, cognitive, and psychological development. It disrupts the victim's ability to attach it to an adult caregiver. And so the effects of which we see are focused more so on social and emotional development in the child and the way that they develop attachment relationships to those adults in their environment, the way that they interact with their primary caregiver. And we know as child life that when a child experiences trauma and when there are disruptions in social emotional development, that affect the child's ability to attach, that those effects of that challenge to attachment has the potential to influence the way that the child perceives the world, the way that the child interacts with the environment, the way that the child interacts with others, the way that the child develops relationships, not just in the here and now, but with the potential of it affecting the way that that child, an individual, interacts with others and develops relationships throughout the individual's lifespan. And so that's why this period of time, childhood, especially, 0 to 3, is so important socially and emotionally, because it has the impact to affect the child across the lifespan. So it has very far-reaching ramifications. Often, shock and denial are typical reactions to a traumatic event. Over time, some of these emotional responses may fade, but there are also times where the individual may experience long-term reactions. And so it really depends upon the protective factors of the child, the risk factors that the child has, and how we can promote resilience. Oftentimes it's also, depending on the situation, is the child removed from that negative environment and placed in a stable, positive environment, and how does the child change as a result of that? And so we look at a variety of different factors to help in our assessment, and also to do what we can to support the child, and look at the ways that these different environments and relationships can have a positive impact. Now, some of the trauma symptoms that we see in children that have experienced trauma or are having an experience that they're perceiving as a trauma is that the child may lash out and have feelings of anger. Sometimes they may not necessarily be able to identify the feeling, and so they may need us to help them, depending on the age of the child, in labeling that emotion and helping them to explore those feelings and find a more appropriate outlet or a way to express that anger. And so they may express themselves by exhibiting anger, may not necessarily be able to identify why they're having that feeling of anger that they are, or it may be that because they've seen anger in the adults in their environment, that's the only way that they know how to express themselves, because that's been their norm. And so again, we want to look at the context of the situation, the experiences that that child has, and the way that it's being manifested. Also, persistent feelings of sadness and despair, where they may also have feelings of hopelessness. They may also experience flashbacks to their traumatic experiences. And so if there have been triggers that have been identified, being aware of those triggers so that we can try to avoid those triggers, and also put supports in place to support the child as they're triggered, to help them to remember that they are in a safe place, that they're not in that experience at that moment. But it's not uncommon for those that have experienced trauma to experience flashbacks. They may also have unpredictable emotions. And throughout this semester, as we're talking each week, we'll talk about the impact of trauma on the brain and the way that the individual experiences trauma. And if they've had multiple traumas, it changes the development of the individual. It also changes the way that the brain functions. And because of that, we may see that the child has difficulty in regulating emotions and regulating behaviors. So they may have unpredictable emotions. If they internalize their feelings and internalize their feelings associated with their experiences, it's also not uncommon for them to exhibit physical symptoms because they're internalizing and keeping those feelings in. And so we may see a child with stomach aches, with nausea, headaches. They may also have intense feelings of guilt, like somehow what's happened to them is their fault, that they have caused what's happened to them to happen. And we know that it's ultimately the responsibility of the adults that have facilitated and perpetrated, some of these experiences. And I'm talking about when you have instances of abuse and neglect, that nothing that the child has done has caused those behaviors to happen or occur to them. And so we know that part of our work is to reinforce nothing that you've done has caused this to happen, and that we're here and that we're going to help you to stay safe, and that we believe you, and that we're going to listen to you, and that we're going to do what we can to support you through this difficult time. They may again have that altered sense of shame because they may have feelings of guilt, like somehow it's their fault, when we know that in some of these traumatic instances it's not. And I say in some of these because ultimately in instances where the child is perceiving like their illness and their injury, even in those instances, nothing that they've done has caused them to be diagnosed with that medical condition. And so sometimes children will take that on depending on the age of the child or because of what they've experienced in terms of responses of the adults. They may take on those feelings of guilt and shame that aren't rightfully theirs. They may have feelings of isolation and of hopelessness. And so what we ask ourselves during this is, when faced with adversity in life, how does a person cope or adapt? How do they overcome and withstand? Why do some people seem to bounce back from tragic events or loss much more quickly than others? And why do others seem to get stuck in a specific point in their life without the ability to move forward? And so we're going to look at all of this, and we're going to answer a lot of these questions as we continue in our conversation. What it really boils down to, and what we're really going to want to understand so that we can support our patients and families, is that it comes down to resilience. What are those protective factors? What are those risk factors, and how can we support our patients? Because while part of our discussion will look at how children may perceive their hospitalization and an illness or an injury as a trauma, we also have to look at this other part of this, where a lot of times children that are coming to us in the hospital environment have already experienced various types of trauma and traumatic experiences, and we may see behaviors manifested in the hospital environment associated with those particular traumas or compounded complex traumas. And you add the illness and the injury on top of that, then that's an additional trauma that they're experiencing, or if they're perceiving it as an additional trauma. And so we're going to want to be aware of some of these responses so that we can identify them and so that we can advocate on their behalf, and also do what we can to be supportive and to tailor our therapeutic interventions accordingly. So what is resilience then? Resilience is the capacity to recover quickly from difficulties, a certain innate toughness in the individual. It's the ability of a substance or an individual object to spring back into shape, what's also referred to as elasticity. It's how well a person can adapt to the events in their lives. So how do they pull from their strengths, and how do they overcome challenges despite having different risk factors? What resources in that individual's proximity can they draw from to draw that strength to be able to overcome the challenges that they're facing? So there's what's known as risk factors, and these risk factors are certain factors that increase the likelihood of a negative outcome, and these protective factors are these factors that actually mitigate or decrease or to lessen the severity of these risk factors. So do they have more risk factors, or do they have more protective factors? And are the protective factors stronger than the risk factors? And how do we really promote and emphasize and encourage the protective factors so that they can outweigh the risk factors so that the outcome leans more towards positive? Risk factors are stressful situations and chronic adversity that hinder children's successful development. These risk factors can include poverty, or a single parent household, or if they've had the death of a primary caregiver, if they have experienced abuse and neglect, if there's mental health issues in the family, if the child is 0 to 3 and there are multiple stressors in the home, financial stressors in the home, this can increase the risk for child abuse and neglect. Does the child have a medical condition, and are they between the ages of 0 and 3? This can also be a risk factor. Protective factors can include having access to community resources, having strong support systems, whether they be within the family or in the community, or having a church family These are all examples of protective factors. So there are variables such as family support, a relationship with community or mentors, and a strong sense of self, so that innate quality that outweighs the risk factors. Resiliency then is those attributes of the individual that relate to social competence, problem-solving skills, autonomy, so the ability to make wise decisions to assert some independence, and a sense of purpose. Now, why is this important then? It's important because everyone has resilience, and a person with good resilience has the ability to bounce back more quickly and with less stress response than someone whose resilience is less developed. So as child life specialists, we always come from a strengths-based approach. We're always looking at the dynamics and the interactions and the child, the healthcare variables, the family variables, the child's characteristics and variables to identify those strengths so that we can do what we can to enhance, to promote, and to support, to help that child in developing those strengths so that we can be promoting that resilience. Now, resilience doesn't mean that the person doesn't feel the intensity of the event or problem. What it means is that they found a good way to deal with it more quickly than others. And so we want to do what we can, again, coming from a strengths-based approach rather than a deficit model, and looking at our children and families to help them to build upon those strengths as they're encountering hospitalization in the healthcare environment, and as they're navigating new diagnoses and different medical tests and procedures, and as they have potential for compounded trauma or multiple stressors, how can we help them to overcome and to employ those coping mechanisms for success? Now, children are resilient. What we want to do is we want to build on that resilience, because reducing the effects of adversity on children's healthy development is really essential and integral to the progress and prosperity of any society. We understand that when a child experiences trauma, and if they have compounded complex trauma, and they have PTSD, and if they are experiencing toxic stress, what ends up happening is they're in a hyper state of arousal, and your body can only maintain that for so long. And we start to see challenges to health. It affects the individual's health. They're more inclined to develop certain medical conditions if they're experiencing a certain level of stress and trauma over a long period of time. So science tells us that some children develop resilience or the ability to overcome serious hardship, while others do not. It's not necessarily the choice of the individual. It's not that the child says, oh, I'm going to decide to develop resiliency. There are certain factors. There are certain innate factors, internal biological factors that are contributing, and there are also environmental and relationship-related factors to consider. Protective experiences and coping skills on one side have the potential then to counterbalance adversity on the other, which is why we as Child Life know we're assessing coping, but we're also assessing what coping strategies the child is using, and are these healthy coping strategies that are going to aid and support the child long term, or are these maladaptive coping strategies that may be working at the moment but are going to actually be harmful for the individual long term. And if that's the case, we as Child Life introduce and talk with the child and the family to discuss new coping strategies, support the child as they're rehearsing these coping strategies so that we can help them develop positive, healthy coping strategies that they can use throughout their lifespan. So resilience is evident when a child's health and developmental tips towards positive outcomes, even when there's a heavy load of factors that's stacked against them on the negative outcome side. So there are some factors that predispose children to positive outcomes. And so we're going to take a look at that. The single most common factor for children who develop resilience is having at least one stable and committed relationship with a supportive parent, caregiver, or other adult. So having that one adult that believes in them and roots for them and encourages them, that is the single most important factor for children who develop resilience. And we're going to go back to that time and time again. Having that one person that says, you can do this, I believe in you, I know that this is challenging, but you can overcome this. having that one relationship contributes to developing resilience for that child. So supportive relationships, adaptive skill building, and positive experiences are the foundation of resilience. And so we as Child Life want to keep this in the back of our minds as we're tailoring our plan of care, as we're developing therapeutic interventions. Are they supporting relationships? Are they promoting skill building? Are they contributing to the development of positive and appropriate healthy coping mechanisms? And are we creating a safe space for that child to where safe space meaning where they feel free to be themselves and where they know that they're going to be received with unconditional positive regard? Are we promoting a positive experience for them in the healthcare setting? Are we contributing to that foundation of resilience? Children who do well in the face of serious hardship typically have a biological resistance to adversity, and they have strong relationships with the important adults in their family and in their community. And we know sometimes family relationships and dynamics can be hard. And so what other supports then can we put in place if that's the case, if there's dysfunction in the family? Is it an opportunity to support the family and get them connected with resources to foster those healthy relationships, or is it that we help them to identify other supports that they have access to help them if their family isn't present and isn't able to be that for them? Resilience is the result of a combination of these different protective factors. It's the interaction between biology, so what's innate in that child, and the environment. So what is the environment or the environments and contexts within which that child works and plays? And all of this interacts to build a child's ability to cope with adversity and to overcome threats to their healthy development. So these factors that predispose them then include supportive adult-child relationships. And we as Child Life may be in a position and may have an opportunity to be that supportive relationship. We also want to create, again, an opportunity for that child to develop a sense of control and mastery, to recognize that they have strengths and that they have worth and value. And give them opportunities to practice that autonomy. So building a sense of self-efficacy and perceived control, providing opportunities to strengthen adaptive skills and self-regulatory capacities. And we do have the opportunity in the hospital to help that child to have opportunities for choices and to make wise decisions, to be a part of their healthcare team, to be a part of the healthcare decisions that are being made about them, and to really identify when they're doing something well. And we can tell when they're practicing. So identifying and acknowledging their efforts and identifying those self-regulatory capacities. And then also being sure to look at the child as a whole, right? Which is something that Child Life is known for. We're looking at all the facets of that child and of the individual and mobilizing sources of faith and hope and cultural traditions. When I think of hope, I'm thinking about the paradigms of play and how we use play and understand that play as hope is something that we use and that we promote and that we facilitate when working with children in the healthcare settings. And so we want to, again, take into consideration the entire picture, do what we can to support the child, and do what we can to support the child in learning how to cope with manageable threats, and because we understand that this is critical for the development of resilience. And so we want to, again, be identifying those strengths, providing that support. And we know as Child Life that we are in a unique position to be able to strengthen resilience in children, because we understand with our firm foundation and understanding of child development and child development theory, and in understanding Lazarus's coping theory, which we're going to talk about over and over again this semester, and that you'll hear reinforced in your textbook readings and in our class discussions, that we want to do what we can to support the individual as they're coping with stressors and as they're appraising situations for stressors. We want to do what we can to help them identify the resources that they have available and the different coping mechanisms that they use to overcome obstacles, and to help them understand that they can overcome what comes at them and what they face. It's never too late to build resilience. The brain and other biological systems are most adaptable early in life, which is why Our role as child life specialists and our understanding of early childhood is so important. Age-appropriate, health-promoting activities can significantly improve the odds that an individual will recover from stress-inducing experiences, which is why our role in this is so important, because we understand age-appropriate activities, and we want to do what we can to improve the odds that that child is going to recover from stress-inducing experiences. We also incorporate physical activities, gross motor activities, stress reduction practices, guided imagery, incorporation of aromatherapy, music therapy into our practices that reduce stress. And we also actively engage in facilitating programming that actively builds executive functioning and self-regulation skills, whether it be social skills groups or just opportunities for socialization, because we understand that this can improve the abilities of children to cope with, adapt to, and even prevent adversity in their lives. And so we want to take every opportunity that we can and take all of this into consideration when we're developing our plan of care and when we're identifying the needs and assessing for the needs of that patient and developing our therapeutic interventions. We want to not just take what's right before us in the here and now, but again, look at the bigger context and all of the experiences that that child has had that we're now supporting them through, or how it's made them who they are, so that we can do what we can to help them identify those strengths and their bravery and what they're good at and the skills that they have developed and the coping mechanisms that are healthy that they are using, so that we can draw from all of that to help them with their healthcare related experiences. So I want you to be thinking about all of this as we continue to build on our conversations as we move forward this semester and as we move forward in our conversations in this class. And I want you to constantly just be thinking about, how am I going to apply this? How is this going to be applicable? How am I going to integrate this into my practice? How am I going to use this information to support that patient? How am I going to use this information to advocate for that patient and for that family? And I'll be asking you questions associated with this, as we continue in our conversations. But I do look forward to continuing our conversations, and I do hope that this first class session you found to be helpful and just as a way to set the tone for our conversations, for our remaining conversations. If you do have any questions over any of this content, please don't hesitate to reach out to let me know, to ask questions. I'm happy to provide examples, and I will provide examples, and I'll do what I can to draw those connections and help you in integrating and sharing with you what this looks like in your clinical work, or will look like in your clinical work as you continue to move forward. I do look forward to having this semester with you, and again, if you have any questions whatsoever, please don't ever hesitate to reach out, because I'm happy to be a resource and to clarify for you. Have a great rest of the week, and I look forward to talking with you during our next class discussion.